Hey guys, Laura Beth here. I'm one of the co hosts of your new favorite podcast, Shit You Don't Know. Heather and I decided that episode 2 about end of life care from the medical perspective was so long and so in depth that we're going to be cutting it into 2 pieces. So, what you're about to listen to or watch is going to be the first half of that episode. Remember to like, review, subscribe, recommend, tell everybody you know, and send us any of your questions at shityouDon'tknowpodcast@gmail.com.
That's it.
We're live again. Yeah.
We're
I don't know
live.
why we
Yeah.
always act so surprised by that.
Because we are. We're not acting. We are. It counts us down. We're still shocked. Anyway, so hi everybody. Welcome. Welcome to Shit You Don't Know, the podcast where real life meets real talk. We're your hosts. I'm Dr. Laura Beth Martin, and this is
I'm Heather Matchett, a
I'm a
pharmacist.
pharmacist. Go ahead.
Okay, outtake.
Keep going. Keep going.
I'm Heather Matchett.
I'm a pharmacist, and she's a nurse with over 40 years of experience and plenty of stories to tell. Heather again hasn't slept, so that's her excuse. I don't know what mine is. Go ahead. Finish the intro.
We're diving into the life lessons, mistakes, and wish I'd known that moments that can change the course of your life. So join us for a mix of humor, heart, helpful advice as we cover the shit you don't know. Your go-to guide to the shit no one fucking told you.
That part.
Yeah. For
So
real.
how's your week going? Today's only what, Monday? Today's Monday, right?
It's been the longest. It's been the longest week ever.
It's the longest week ever, and it's 5:45 Central Time.
Right. I just came off a 4-day stretch where I was the charge nurse, and I don't know. I might be a little advised out. Like after
You're done. You're like, I've already been with I've been with the people. I've been with the masses. I have given all the wisdom away. I have nothing left. So
right. I did, like, while I was fixing assignments for the unit last night. I was going through my agenda and trying to make notes and be like, okay, what am I gonna say? Like, what am I gonna say? Like, I don't know. Anyway, so I did nap today though, so that's good. I'm not completely unrested.
I don't know how you come off of 12 hours and like stay up until I don't know how you do it. And then try to sleep.
Insanity.
Fair. That's fair. So, I went back to work Saturday. I worked Saturday, Sunday, and then I was off today and went back to the surgeon for a checkup, which was great because I did a thing this weekend I have never done before and took my own stitches out.
Rebel.
Without a cause. Like, they're gone. Look how beautiful. Folks at home, look how beautiful this looks.
That does look very nice.
You think you need people that have MD. Sometimes you don't. I'm just kidding. Don't do that yourself. No, I had surgery on a Friday, and normally, they're going to come out in like 7 to 10 days, roughly. Well, then we went into the holiday, and so my post-op appointment was basically like on day 16. And Saturday I was at work, and I had my brace on and everything, and the stitches are driving me nuts. And like I was doing something, and I had my hand in writing, and I was like, why does my hand smell like death and stinky feet? Like, it was so. It was awful. Like, I was like, this is like, what is going on? Because you can't wash the stitches. But I mean, I'm washing the back of my hand. I'm washing in between when I change the bandage, like with alcohol swabs and stuff. And so when I got home that night, I was like, that's it. And I just got all the tools, and Steve was not excited at all. He had to hold the light. And I was just like, shoot. I couldn't stand it anymore. They had to go. And like within an hour of taking them out, like, I've got stuff, sloughing off, and it looks beautiful. I mean, it's not as pretty as a baby's butt, but we're getting there. I mean,
did your surgeon at least compliment your good work?
Yes, I told them I was available if they wanted to hire me just to sit around and take stitches out. I felt like I had the experience now. Like, I don't know why I'm paying you guys, because no, they were actually really proud. They're like, yeah, we get it. It was a long stretch. I'm like, I just couldn't do it another 2 days with the funk. I could not. This was disgusting. It had to go. And the stitches were embedded. Ugh. Those are not
Yeah.
fun to dig out. Folks at home, if you don't know what embedded stitches are, it's when the skin starts to grow over the stitch. Um, you got to dig that sucker out. So they had to go. I was done. So I'm not completely, but I'm getting there. They were proud. I'm proud, and I got Chick-fil-A out of it, so it was a good day.
The Jesus chicken. You gotta love the
It
Jesus
is the
chicken.
Jesus chicken. I know people have strong feelings about Chick-fil-A, and I'm sorry about that. Um,
I
I
mean,
really am. But
I myself have strong feelings about Chick-fil-A, but sometimes you can't resist the call. I mean,
I get it. I do. But there's something about those fries and the Polynesian sauce that just calls your name, and you gotta have it. You just I don't know. I hate that people have feelings about it because it's really good. Here's the thing. I always want it on a Sunday, though. You ever notice that? Did that happen to
yes.
you? You're like,
Yeah.
what sounds good today? Chick-fil-A. They're closed because it's Sunday.
It's our rebel spirit. That's what it
It
is. It's
is.
our rebel
It
spirit.
is. I feel like if Chick-fil-A can be closed on Sundays, then pharmacies can be closed on Sundays.
True. Except
I
for
think
that
that's
you're not the charge nurse getting the after hours phone calls about how there's no pharmacies open and they can't get their meds.
okay. You know what? We're going to have an episode about We're going to put that on our list because until Walgreens and CVS started their 24-hour pharmacy nonsense, hospitals used to send you home with a 3-day supply. Anybody remember that? They sent you home with 3 days worth of medicine if it was a weekend, and that way you could get to the pharmacy on Monday. There was none of this. You're getting out of the ER at midnight and go get your augmentin.
We do at our hospital have a discharge pharmacy, but you have to have everything to them by a certain time. And so
Of
a lot
course
of
you
times
do.
they will they will send you home. Now whether or not that sack of meds is right or not, well, that's I guess that's on you to make sure that that's the case. But
Don't
there
know.
does seem to be a lot of. I mean, no system is perfect, of course, um,
No,
but
definitely not.
yeah, but we do some semblance of that where I'm at as well now. For a long time we didn't, and those calls were a lot more frequent. I think the thing that we get calls the most after hours is pain medicine,
Oh,
um, because they'll
thousand
get home and
percent. Yeah.
realize that they don't have
Mm-hmm.
any, and
Yep.
of course, you know,
Yep.
getting an on-call physician to call in narcotics for a patient they've never seen is usually a
That's a
hail mary.
no.
Yeah,
That's very often a no. Not just a no, but a hell no. It's not going to happen. So,
right, right.
oh, all right. Well, Heather has made our outline for today, so I'm
Yeah.
gonna let her dive right in and lead the train, direct the train, navigate. With I don't know. She's in charge today. Okay,
Oh,
she's in
it's good.
charge. I'm not in charge.
Buckle up, y'all. So, I guess we kind of left off with, I guess we left with a cliffhanger,
Yep.
as be it as it may. So this week, I kind of wanted to continue talking about, just like we were talking about death and dying, and we were talking about like the financial aspect of that. And so I wanted to like kind of go through, like walk people through the physical aspects of dying, and then just the things that if you yourself are transitioning to hospice or your loved one is transitioning to hospice at the end of your life, like what are the different ways that people come to that. And
Right.
so I kind of wanted to even talk about like what is a terminal diagnosis. So
Mm-hmm.
if you have a terminal diagnosis, meaning by hospice standards, a terminal diagnosis is something that is potentially going to end your life within 6 months. Okay, so that can be a cancer diagnosis. It could be a heart failure diagnosis. It could be a respiratory failure diagnosis. It could be end stage liver. It could be end stage lung, like any of those kinds of things that could potentially end your life within 6 months or will end your life within 6 months are what's considered a terminal diagnosis. And so You have to have a terminal diagnosis in order to be accepted into the hospice program, and that's across the age spectrum, whether you are a pediatric
Mm-hmm.
patient or an adult. So what does that mean for your benefits, right? So most people fall into the categories of either they have disability, which means that they probably already have Medicare or some type of gap insurance, like Medicare, Medicaid. Medicare, of course, is you have to be a certain age to receive Medicare. What is it now? I know they raised the Medicare age recently. Do you know what it is? Is it
Um,
67?
we should know this.
We probably should.
Here's
but like, but
here's
it
where it gets
varies.
muddy, okay? Um, because we have so many patients that end up on disability before they are actually what you consider true Medicare age. So that muddies the waters a little bit. And then on top of that, you've got patients who qualify for Medicare, but they're still working.
Right.
So they have commercial insurance and then they have Medicare, but at the pharmacy, we don't ever see the Medicare side of it if they still have commercial, because you always want to hold on to that commercial insurance. It's usually going to pay better, especially at the pharmacy, than a Medicare plan is. But we will, while Heather is chatting, I will Google that real quick
Well, I know
because I
that there's
don't
like
know anymore what it is.
there's
It's
kind of like a
crazy.
staggered age effect too, because like
That
I know
part
my
too,
mom,
yes.
yeah, because my mom's generation, like they qualified at a different age range, because she was born
Yes.
between a certain year. So I think for
Yes.
her it was 62. So
Yes, it did. Mhm.
but so then
It
you
still
have
says
your
that though. It's like it is still tiered.
yeah.
So like you can sign up at 65 for like full benefits if that's when you start receiving your Social Security payments, because those kind of go hand in and those go hand in hand. But it also says if you start at 62 receiving those retirement benefits from Social Security, um, then you're automatically enrolled 4 months before you turn 65. So there's some minutia involved, and I think that also point there. It's even more complicated. I just pulled that down real quick, but I think that also points back to how complicated it is to navigate the system that
Mhm.
we're in. And it's really no matter what age you are, but specifically as you get older, it's very hard to navigate like Medicare versus private insurance. And I know we're going to cover that in some later topics, but I've had patients and employees who thought, hey, I'm going to cut back. I'm going to scale back. I'm going to partially retire and actually get with Medicare and Social Security and have everything they think set, and then come back and find out, oh, wait, I won't have benefits yet. Like they can't. So it's frustrating. I can't. And then on top of that, if you aren't already on Medicare and you have a terminal diagnosis, like I would just sit down and cry. I think I'd just be so overwhelmed.
Right, because the private sector does not pay for hospice a lot of times,
Wow.
which is something that a lot of people don't know. And so then you're faced with, oh crap, now what do we do? And then let's say you have an insurance that pays for hospice, but you're the one who's employed. So now you're facing, okay, now I have to figure out how much my Cobra is going to be, because once
Right.
you stop working, you
Right.
know, you've got to figure out how you're going to be able to afford to actually keep your insurance while you're going through the hospice process. So
You
in some,
know, I did have a patient that happened to, and they were actually single, divorced. This has been years and years ago, and they they actually ended up missing treatments for about a month because they lost their commercial insurance, and there was a lag time between that and when they qualified for Arkansas Medicaid. And I just felt like that was so criminal. Like here's this person who at that time they were still actively seeking treatment. It wasn't long after, just maybe 2 or 3 more months past that we went on to hospice. But, to look at someone and know that they're actively really ill and struggling and to not die, but they can't get Medicaid, and they were straight up told by the hospital, like, we can't administer any more of your chemo until Medicaid tells us that you're covered now. I mean,
That happens all the time where I'm at. All the time. We have patients. In fact, I was shocked actually, because, when I came from the University of Arkansas, and I was there at the University of Arkansas for a very long time. And so I kind of got a front row seat to its evolution, from when we went
mhm.
from ragtag, a county hospital where you have to bring your own pillows if you're having your baby
Yes,
there because they never have any
yes,
supplies,
yes,
to like a world class state of
yes.
the art center. And when I left the University of Arkansas, we had not just a medical oncology unit, we had several oncology floors. We
Yes,
had,
yes,
both
yes,
autologous and allogeneic
yes,
stem cell transplant available. We had
yes.
all the things. And so, and they're kind of starting to do that process at my job now, but they're in it's very infantile stages. And I do understand, cancer is big money, cancer is big business, it's a major driver, and it is one of the hardest kinds of healthcare to get when you're in a healthcare desert, which we are here in West Texas. So
Yeah.
it's really difficult. And if you do have, like, even sometimes if you have private insurances, a lot of those private insurances just don't pay for certain kinds of treatments to be administered in
Mm-hmm.
different ways. Like, all of that stuff is dictated by what kind of plan you have. And the same is true for hospice. So if, say, you have breast cancer and you're 40 years old and you have exhausted all your treatment options and now you're going to hospice, you are now in that group of people that is faced with, okay, does my insurance pay for this? And if so, like, how do I access those benefits? So most people, if you have a major health diagnosis like a cancer diagnosis, you probably have behind the scenes somewhere a nurse case manager. And so
Mm-hmm. Yeah.
when you get a cancer diagnosis, and this is just FYI advice for anybody out there, you're going to need to make friends with your nurse case manager, because that's the person who's going to advocate for you on the other side of the screen. And you definitely are going to need that while you're going through any kind of life-saving terminal diagnosis type treatment. Um, because, they can save you a lot of money on things that maybe the hospital doesn't know. Like, there are certain chemotherapy drugs that are reimbursed at a higher rate if they're given in an outpatient setting. And then this also comes into play. Now, you can't find very many hospices who will do it, just because of the cost and expense. They want you to be done with all treatment, but
Yes.
technically, they have to pay for anything that's palliative. And
Yes.
fighting that
Yes.
fight is a lot more. It's a lot more difficult with Medicare, but it's sometimes a lot easier with private insurance. So, everything kind of sort of has its checks and balances. Um, because technically, when you come on to hospice has a payment bundle of things that they pay for, especially if you have the Medicare benefit. And but they will not pay for any kind of treatment that's related to your diagnosis. It's simply palliative. So you can have,
Right.
like, if you come on to hospice for, say, breast cancer, then hospice takes care of all the medications related to your terminal diagnosis. So any of your comfort meds, all those kinds of things, but they will not pay for meds that are not related to your hospice
Right.
diagnosis. So,
Right.
yeah. So,
And will you kind of explain and make the distinction? Because some people may not understand with hospice, we take it for granted, but when a patient chooses to go onto hospice, they and their family need to have that understanding that we are no longer pursuing um, a cure or a recovery. So
right.
would you kind of explain that a little bit? Because I think that's a great, I've had families like get really angry before, and I'm thinking, y'all don't understand the basics of hospice. So like maybe shed some light on that for us as well.
So yeah, so okay, so if you have exhausted all your treatment options with breast cancer, and they're saying that there isn't anything left that they can do for you, and they're recommending that you go home on hospice. So when I would have those conversations with family, because I do think that after being a hospice nurse, this is something that really gets missed, especially if you have an oncology doctor who is not adept at pulling in the palliative care people in order to help
Mm-hmm.
facilitate those end of life discussions. And I have worked with oncologists who are both great at that and terrible. So, and it's just varying degrees. And so it takes a little bit of self-awareness, I think, on the practitioner's part to know their strengths and weaknesses when it comes to that, because it's a very important
Mm-hmm.
conversation. And typically it happens in layers. So normally when I'm approaching a patient like that, I ask them, the number one goal is determining, what are your goals? Like, what are your goals? And
Mm-hmm.
sometimes just being able to get them to voice, okay, I want to go home, I want to be comfortable. And if they say those words to me, I say, okay, let's talk about what comfortable means. So comfortable
Right.
means we're not having any pain, we're not having any anxiety, we are not gorked to the point that we can enjoy our life, we are, being able to spend time with our family members. Like, let's flesh out like what those actual goals are. Do you have a date in mind? Is there something fancy you want to do before you leave this world? Because I
Right.
am a strong believer that people, they hang on for those things. And sometimes just having
Yeah.
a goalpost in mind, helps you sort of figure out how you're going to care for this patient. Ideally, like, what would make my heart sing as a hospice nurse is when I went into the home to do the admission, that the family had already talked about a DNR, that we're not trying to have that discussion while I'm there trying to admit them for hospice. And
Mm-hmm.
what a DNR is a do not resuscitate order. And there's two kinds. There is an inpatient facility DNR, and then there is an out of hospital DNR. And when you're in the home, you ideally want to have both things. If you decide to be a DNR, you want to have a hospital DNR and you want to have an out of hospital DNR, because that covers things like the ambulance ride home.
Mm-hmm.
I have had hospice patients code on the way home from the hospital with no out of hospital DNR in place. And you want to know what happens is that the ambulance driver has to do all of the things that he is made to do by the law and bring that patient back to the ER. And that code has to be continued until someone says, okay, stop. And in the field, this is very important to know. In the field, the family cannot make that call. So once CPR starts, you keep going. So that's definitely not a conversation I want to be having the first day that I meet you. It would be nice if those things happened prior to you getting enrolled in hospice, so that we're not trying to
Right.
figure out, what actually it is that comfort means. Um,
Right.
can you
And I
come
think
on
it,
hospice without a DNR? Yeah, you can. It's not a requirement.
right.
But 99% of the time when a family member wants to do that, it's because they're uninformed and they don't really
Right.
understand or know what that
Yeah. And I think
is.
that's for those of us in healthcare who have attended a code, worked a code, um, there's a lot of ways to describe it. That for me, that's one of the most traumatic experiences in healthcare. And that's from a pharmacy perspective. You don't think about pharmacists being there, but somebody has to reload that med cart, and somebody's got to be there. Like in the hospital, when codes are called, pharmacists are called to the codes, and so they
Yes.
witness all of that. And so I don't think the general public understands how violent resuscitation, like it is violent. And so my husband and I've talked about this many times. We've had such an explosion in healthcare in the last 50 to 70 years. The silent generation and the baby boomers have literally watched medicine grow from its infancy of, where there weren't antibiotics or there were only sulfa antibiotics, and they remember the polio vaccine being developed, to now, we have ventilators and we have dialysis machines. We have all this crazy, almost sci-fi technology, it seems like, that can keep people alive and extend their life. And so for some people, there's this misconception that, well, if I sign if I sign a DNR, then they're not going to do anything to help me, and my life is over. And it's like, well, let me explain to you, because if you're 82 and we have to call a code, and do chest compressions and ventilate you, it's not going to go well. It's not going to go. I mean, like we may get you back and you may be on that vent, but your quality of life and the pain, the physical pain and the trauma and the emotional pain that patient has to go through, like to me, there's a very, very different, it's a very different situation when we're dealing with someone who has multiple health issues and age not on their side versus an 18-year-old we just pulled out of a car wreck that we're trying to, allow their body to recover and, their coding or whatever. I don't know how you would want to speak to that as well. But for me, it, Meemaw at 93, sign that DNR, y'all. Sign it.
Well, and that's one of the things too that is really, really important when we go back, just kind of linking back to that whole power of attorney situation.
Mm-hmm. Yes. Yes.
Because in a situation where,
Yes.
Mima is at the end of her life and it was Mima's wish to sign a DNR, we also have to understand that next of kin or that power of attorney is the only person who can revoke that
Mm-hmm.
DNR.
Yep.
And I have definitely seen that happen. And so, I was a young nurse at this time, and I probably had only been a nurse like maybe 2 or 3 years. And I remember we had he was a younger dude that his family was not. He was very on the same page about what he wanted his
Mm-hmm.
expectancy, what the end of his life to look like was, and his family was not at a point where they were really willing to accept that.
Yeah.
And so, of
Yeah.
course, he coded, and his mom was like, do everything, do everything, do everything. And he had terrible graft versus host disease. His whole oral cavity was nothing but mush. And I remember that doctor pulling her into the room and saying, then you will stand here and watch everything that we do.
Yeah.
And,
Yeah. Yeah. I don't blame you.
and of course, when she saw everything that had to be done, she was like,
Mm-hmm.
okay, stop, like, let's
Stop.
not do this.
Stop.
But that
Yeah.
emotional response to, oh my gosh, and I mean, I have to look at my own self in these situations. Had I been there when my grandma died, I'd have been like, save her,
Right.
because
Right.
I mean,
Right.
I love my grandma. That would have definitely been my first knee jerk response, to been like, do everything, even though I knew that that's not what she wanted to do. So who you choose to be your advocate in your times of inability to make your own decisions is extremely
Yeah.
important. It's definitely important in a hospice situation. And it is very, very hard for the healthcare professional involved to navigate situations where even the two of you are not on the same page.
Yes.
And that
Yes.
is the thing that's going to cause hospice care to be hectic down the road
Yes.
when it comes
Yes.
to the point where we're doing invasive symptom management. If
Yes.
the person who is tasked to administer your medications is
Right.
not on board with what those medications can do.
Well,
And
and I've been in family meetings, and I'm sure you have too, for folks at home. When you are in the hospital, a team of people takes care of you, and depending on the level of care that you require, so the higher the level of care, the more likely we're going to have a team meeting about you, very frequently. And there's times we have to bring the families in for a family meeting because we're to the point where we've exhausted everything and we don't, like, some decisions have to be made, whether it's to turn a ventilator off or to start dialysis, to stop that, like those sorts of things. And I have watched families and listened to them say, I know that my family member doesn't want this, but I just can't turn that, I can't be the one to turn that vent off. Like, I know this is not what I mean, and said it multiple times. And it just blew my mind because I won't go into the specific details of that patient for their confidentiality, but I know that patient was in pain. I know that they experienced pain multiple times a day. I know they did because of the
yeah,
procedures we were having to do, the care we were having to provide. And it just floored me. It's not that I don't respect the family because that's such a hard decision. to sit there when it's somebody you love and go, yeah, we're just going to turn it off. But that person was not conscious. They were not going to regain consciousness. They never did in the 3 months that I cared for them. And then they were another month in a different facility before they actually were allowed to pass. And it, there's no way that person suffered the entire time physically. And of course, we don't know what they could hear or understand. And that's a whole other podcast, probably. But I just feel like that was some sort of torture that that person was made to go through. And I know their family did not mean it to be. They absolutely adored this person, and that love was very, very evident, but they just could not, quote unquote, bring themselves to make that decision. And those conversations need to be, I mean, and she'd had the conversation, but they still were going to do what they wanted to do anyway. And it was awful. It was awful.
Yeah.
I really,
Yeah.
I wish there were some way for people to see sort of behind that velvet curtain of what it really looks like when you're caring for people who are the sickest of the sick. And those awful decisions need to be made, and what the patient has to go through to meet
Yes,
somebody
and I
else's.
do think that sometimes those you know, when we start doing things to people, like there are certain things, the way that I approach have always approached cancer education, because there are certain kinds,
Mm-hmm.
like my head and neck cancer patients, I always try to take the time to remind them that the treatment for head and neck cancer, even with the best prognostic outcomes, is rough.
Yes.
And so
Yes.
there are things that we need to do to you on the front end to help you maintain your ability to continue treatment, because that's the goal,
Yes.
you know. And I think that there's a difference in the kinds of conversations that doctors need to have when we're doing things like peg tubes, so that the
Yes.
patient understands that, you know, we're doing this not because so that you can get through the treatment, because if we're radiating, you know, the entire radiation field is your esophagus, it's going to impede your ability to eat, you know. So being upfront about those kinds of things versus, say, you have a locked lung because you have a malignant pleural effusion, which means that you have
Mm-hmm.
either disease in your lung or metastatic disease, and that is causing, because cancer loves water. So if you have this cancerous process going on in your lung, it's going to draw fluid into that pleural space, and so now you have a pigtail catheter that is going to help you drain that fluid off, or a peritoneal
Yeah.
catheter, you know, same things. And I think that there are a lot of patients that end up with those kinds of devices that don't understand that those are terminal devices. So that's not something, for the
Mm-hmm.
most part, occasionally in like gynecological tumors or things like that, where they are needing paracenteses or where they're taking fluid off their belly, then you can sometimes, that's not an end of life situation, but 99% of the time it is. And that's often a missed opportunity where doctors can really explain to the patient
Yeah.
that, you know, this is the body process that is happening when we put this device in. And
Mm-hmm.
I think that that's probably one of the biggest gaps that we have, is that when we start to, I call it the problem cascade, when you're going over the
Yeah.
mountain of all of the things that start to pile up on you,
Mm-hmm.
particularly in a terminal diagnosis case, because then everything starts to kind of snowball.
Yes.
um
Yes.
it's like we're reaching the top of the peak, and we're sitting right here, and this is a really great opportunity for a doctor to come in and say, okay, this is what the expected course of your treatment looks like, this is what we can offer you, this is,
Right.
you know, a reasonable outcome. And I so often see those conversations never happen.
And
And
I don't know if it's bedside manner or more of a, because it is so common knowledge to physicians
mhm,
that they forget that the terms they're using, like, that patient is not going to extrapolate to the direction you think they're going to.
no,
And I mean, that happens to me in pharmacy all the time. And I've learned over the years that I have to speak to patients very clearly and very, I wouldn't say rudely, but I do. I'm I mean, I'm blunt. I have to be blunt. I have to be very, very straightforward and use very simple terms. And it's not because people are necessarily dumb or ignorant or uneducated. It's because many times this is a very confusing health issue, diagnosis. They're overwhelmed. They may be in a little bit of shock, depending on what it is. There's a whole list of reasons they're not going to hear everything I'm going to say to them. So I just think that there's a baseline assumption of, well, if I say this is happening, then the patient's going to know that that's what's next. And no, they don't. They
And
absolutely don't.
there are a lot of like cultural aspects, to those
Mm-hmm.
conversations too.
Sure.
And I've had many occasions where they're like, we're not going to speak about that, we're not going to speak it into existence, or things like that.
Yeah.
And if you have a family member like that, it can be very difficult to have
Mm-hmm.
real conversations about, okay, so we're putting this pleuric drain in, and do you understand what that means? Do you understand
Right.
why we shouldn't be hooking a bottle up to this every time you feel a little full, like, just kind of explaining the pathology. But I also think too that time management is or just having time for
It doesn't
patients to
exist.
know it,
Mm-hmm.
and that is
It
the
doesn't
big
exist.
thing too, is that
Mm-mm.
we don't have time. I can't tell you
No.
how many times I'll walk into a patient's room to start their chemo, and they'll have all the information sitting there in a little folder and all nice and neat. It's been printed out, and here you go. This is about your chemo, and a cancer diagnosis is more than just the chemo. The cancer
Yes.
diagnosis is taking care of yourself after chemo and keeping
Yes.
yourself reasonably protected from infection. And, we're going home with central lines, and we're going home with all
Yes.
these things. And,
Yes.
I
And
just think,
patients who are listening right now, when you have all of those things or you're going through all those things, what we mean by taking care of yourself is you don't go to church. You don't go to the grocery store. You're not going to bingo. Like, you don't walk around immunocompromised and then say, well, I prayed about it and Jesus is going to take care of it. Let me tell you, Jesus doesn't need you at Sunday school that bad. He does not. If you're going through chemo or radiation, or you have a central line, or you have a significant health issue, if you've had a C-section, if you've got a new baby, like, stay home. Stay home, and take care of yourself and your family. It's unnecessary, and we don't need you there. I'm
right.
sorry. There's going to be some people who probably don't want to hear that, but I have literally seen patients, actively many, many, many times. It's not an isolated thing. And I don't know if it's just a Southern thing, you know, like, I don't know. But it's like, we think if the doors are open, we got to be there no matter what, because attendance counts. And, if we're able to walk to the bathroom, then we can walk to the car and go to church. And I'm like, no, no.
Well, and
Uh-uh.
I think too that, like, I know for my mom, I was my mom's only child. So, of course, when I left the house, there was nobody else there to partner with her, or be a support system. Um,
Sure.
but I mean, my mom never quit doing any of those things.
Yeah.
Never. And,
Yeah.
and I don't even think, like I said, she was at church the week before she died. So, and I think too, though, the difference in between, seeking treatment, seeking cure, being curative, though, is that the beauty of hospice is that
Right.
now you don't have to be so protective of yourself in those ways, and you can say, what,
Yeah.
I've got X amount of months left, and I'm going to
Mm-hmm.
see my friends, and I'm going
Right.
to go to church, and I'm going to be involved as much as I possibly can.
Right.
And so there's kind of like two sides to that, two sides to that
Very
coin.
true.
And I also think that reasonably you can still, when seeking treatment, participate in all those things with a little bit of
Sure.
good common sense. And
Mm-hmm.
and explaining that to them, like, hey, on day
Yeah.
14 after the start of your chemo, your blood counts are going to just be in the trash, and you're not going
Mm-hmm.
to feel good, and all of those different kinds of things. And the beauty of hospice is that you're not experiencing any of that, so that you can go
Right.
out and live your life.
Yeah.
um and so it could be actually a very freeing experience,
Yes.
really, and
I
a
don't think
very
I don't think hospice has to be a scary word. And I think it had for a lot of people that it's off the table. We're not talking about it. But like you're saying, when you reach that point, then you're just like, well, now I'm going to be comfortable. I'm going to take the medicine I need to take to be comfortable. I'm going to see my kids or my grandkids. I'm going to do the things that I feel like doing every day without restriction. I don't have any more doctor's appointments necessarily. Like I don't have any more intensive treatments. It's it's a very different, and I've seen patients just, there's some real beauty in hospice when patients are able to embrace that time and try to enjoy it and not fight
Yes.
that the end is near, if that makes sense.
Yes, for sure. I mean, I think it's definitely, you know, if you allow yourself, or if your disease process allows you to be in a position where you can, because some people don't get that option. But
No,
if your
they
disease
don't.
process allows you to be in a position where you can choose how you want the end of your life to look like,
Hmm. Hmm.
um, there are some really beautiful moments there. You know, there's lots of, I see lots of reconciliation and lots of healing and lots of things that work out that people didn't think would ever work out. Just because I think hospice allows you really to be honest with yourself in a way that maybe you weren't before. You've put aside the hope and the spiritual begging that you're going to get this other kind of resolution that you wanted, which fair. Um,
Right.
because nobody wants to die, nobody wants to
No,
die.
no.
Um, but the acceptance that death is coming can
Yeah.
also open the doors to some really beautiful things if you allow it to. So, but let me circle back to the private insurance option on hospice, because definitely I
Yes.
want people to understand this thing. If you are in that situation where you are going to need hospice care and you are still on a private insurance company, the time for you to explore what your options are is now. Once you get to the point where you're on Cobra, sometimes it's a little bit harder to like change insurance companies. Some, like if you have a spouse who's working, you might have
Hmm.
the benefit of being able to get on their insurance if the termination of your employment um, is a qualifying event. So definitely talking with your HR to see what your plan's qualifying events are, because qualifying events are things like you have a
Hmm.
baby, your baby can go on your insurance. You've adopted, your adopted child can go on your insurance.
Right.
Those kind of things. And most places won't let you switch horses in the middle of a race. So you
No.
have to figure out like what your actual options are. And if you have,
But
and if you,
losing a job does typically, or having to quit in this instance or whatever, that does typically qualify as a change of life for
yes,
most. So,
yes. And it's usually that's usually a suitable thing. You can, a lot of times I've had patients do this, arrange cash pay services with hospice. And just like any other medical bill, you determine what you're going to be able to your ability to pay that. And as long as you're paying on your bill, there really isn't anything that they can do to like garnish your wages or anything like that. So I always tell people, even if it's only $10 a month, as long as you're paying something, if they're cashing that check or they're accepting that payment, then that is an agreement to your terms, and they can't do
right.
anything to. So, or your family. So that's a good part about setting up. But you have to be honest with where you are in your situation, so that
Hmm.
your hospice providers actually know how to work with you. The problem is that we have a lot of hospice companies out there that are for profit, and they are less charitable in those regards. So if you are facing one of those options, you may want to seek out a nonprofit hospice, because a lot of times they have like a little bit of philanthropy. I can't say this word today. um, People donate to them.
Philanthropic
Yeah, that's what I'm talking.
or
Philanthropic. Thank you.
philanthropist. I don't know which
Yeah,
word we're going for, but okay. There you
philanthropy. They have avenues where there are people out there in the community who donate to getting hospice care. There used to be this really great, and I follow them, but I don't think their inpatient center is open anymore. It's called the Zen Hospice Project out of California. They did a
go.
really great TED Talk several years ago where they talked about like all of the different things that they would do in their inpatient hospice to help people transition. And so many beautiful stories. And they are one of those places that's a nonprofit. And so they work really hard to do a lot of fundraising so that people who need hospice care can actually get it at the end of their life. So those places do exist. You just kind of have to look for them. So hospice itself, there's different levels of care that you can experience when you're on hospice. So if you have a terminal diagnosis like cancer, you have like home care, then you have inpatient care, long-term care, and respite. So home care is typically you're at your house, we're coming to your house. Usually your nurse case manager comes once a week. That's pretty typical. Sometimes they have to see you every 14 days. All of hospice is kind of like done on Medicare guidelines just because that's the major payer.
Right.
On private insurance, you don't have to be seen every 14 days. The rules are a little bit different. But if you are on hospice through Medicare, then we do have to see you every 14 days for sure. Because if you are getting like bath aid services or any of the other services they provide, the nurse case manager is the supervisor for those services. And so we have to document a supervisory visit saying that everybody is doing everything they're supposed to be doing. And that has to occur every 14 days. Some people only need once a week. Some people need twice a week. It just kind of depends on the family. Pretty generally, when I was a hospice nurse, I would do the initial visit where we admitted. I would see them again the next day just to make sure that they have everything they need, that we've gotten all the meds that we need, and that people know how to use them. And then I would see them once or twice a week, just depending on what their level of care is. So then if you are getting to the point where, say, I would see this a lot, this was a common situation where both the patient and their caregiver are elderly.
Yes.
Once that patient sort of transitions to the active dying phase, which we'll get into in a second, kind of what that means, a lot of times the spouse isn't able to do the physical work of care. So there's a couple of different little options that you can do. Sometimes you can do something called respite care. And basically, most hospice companies will partner with facilities to say, we will pay you X amount of dollars for 5 days of respite care. And again, respite care is something on a hospice benefit with Medicare that I believe you can use. It's like every 90 days. So every quarter, like every 3 months or certification period, you can use respite one time. If you're going to go out of town, I've had patients, family members need to go out of town for something. Obviously their loved one isn't in a place where they can care for them while they're going to be gone, or nobody else can, then respite is a good option for that. But you also have to have your ducks in a row, because I've had patients die in respite. So, you still need to have all your paperwork in a row. You still need to have everything you need. And when you go into a nursing facility where they are contracted to do respite, you have to provide all the meds, because all the facility is doing is basically just providing the physical care. They're not going to pay for the supplies. You have to provide your own supplies. You have to provide all that. And a lot of times too, some nursing homes will require that the hospice company pick up the equipment from the house and set it up in the nursing home for those 5 days, and then vice versa. Some nursing homes are cool with you using their equipment, but there are a lot of them that will require you to do that. So that's something that you need to be prepared for when you're considering respite. Inpatient care in hospice is nearly a non-existent thing anymore. It used to be that you could bring a person into the hospital, like if they were actively dying, and they could do that, complete that process while they're inpatient. Now, because of the way the Medicare guidelines are, it's very, very difficult. You have to be in what they call an acute situation, like an acute pain crisis, or, we're bringing you in to get your symptoms under control or symptom management. They just don't allow you to do that inpatient option anymore. And then long-term care. So as with everything long-term care, this is where shit gets real, because hospice doesn't pay anything for long-term care. They will pay for equipment. They will pay for medications that are related to the hospice diagnosis. They will pay for supplies, but room and board is not paid for at all um, by Medicare. So, can you go into the nursing home in the middle of your hospice diagnosis? Yeah, you can, but you're going to need to, the same qualification rules are going to apply. Whether or not you, Medicaid wise, you are able to qualify for Medicaid, and and if that's the case, then great. But if that's not the case, then your family has to be prepared to pay that private pay rate until other funding sources can be figured out. So again, this sort of loops back to that whole having your shit together with your finances. You
Mm-hmm.
know, hopefully by this point you have set up a Miller's Trust, your
Yeah.
assets are protected. We're only going off of what you're getting for your Social Security benefit, you
Right.
know, all of those things, so that you can actually qualify to get some assistance, because if they don't, they just don't pay for anything. Now, I've seen it's not always a great idea, just because these facilities are not usually trained and their staff is not licensed. I have seen people utilize assisted living facilities for this part of the process, because you can just go in and pay like a per diem rate. But they
Right.
are very, very, very expensive. And I will tell you from my own personal experience as a hospice nurse that every bad situation I've had with a facility has been with an assisted living facility. Um,
Yeah, I would imagine. Yeah, because the nursing care is going to be really limited in assisted living.
mhm.
We'll have to talk about that. Episode two. What's the difference? But there's just, and they don't have to have that many nights. That's not what they're, to be completely fair, that's not what assisted living was created for. Assisted
Exactly.
living was created to be that bridge between, we don't really want you at home anymore. It's not safe, but you don't need to be in a nursing home yet. You're still very active perhaps. And so it's a bridge to, it's not, they're not going to have the medical stat. They're not supposed to. So I don't think that families who are making that choice, and I think too that something a lot of people don't realize until they have to employ hospice. Hospice used to come years. Now this is years ago, light years ago. They would come and stay. Like, you would have nurses come and be on call and be there, 8, 10 hours, and you might only have to have the patient by yourself at night, or, whenever you didn't work. And that is not how hospice works anymore. And it hasn't for a really long time. But if you have a family member who is in hospice or is actively dying, or, moving through these stages and processes, you on your own. You will have to provide the day-to-day care, unless you can afford to put them in a sort of a nursing home type situation where they are class, and then the hospice will, come in and do some things there as well. But do not at any age assume that there's a company out there for regular folks. I'm sure if you have plenty of money, it can be had. But
Yeah.
but for but for Miss Smith, who taught you algebra in junior high, when it's her time, her kids or her spouse will have to care for her. And that means people have to take FMLA, they have to take leave of absence, they're going to go without, paychecks. It can be a really financially difficult, challenging, bankrupting type situation to have a loved one in hospice, because you've got to provide that day-to-day physical care, and you may not be able to go to work. And if
Yes.
you're if you're fortunate enough, you may still have children at home while you're doing this as well. And that is a rough sandwich generation to be in, where you've got kids and that need you, and parents that need you,
True.
and a job.
And even in my situation, where you have a parent who may need you, who lives 1,000 miles away,
God, I don't know how you did it.
and
I'd have
so
lost my
you
mind.
have to try to, you have to,
You're trying
I
to
knew I
coordinate from states away.
Right. And I probably could have, like, I started down that road, like, because I still had lots of friends. I have several friends in healthcare actually who live in the St. Louis area who were all like,
Mm-hmm.
let me help you, let me help you.
Mm-hmm.
And I was like able to get, my mom's friend's daughter would come over a couple of times a week and clean for her and,
Right.
help her with those kinds of things because she wasn't
Right.
really able to get up and down the stairs anymore. And
Right.
my mom always chose second story apartments. Don't get me started. I don't even like when she moved into the
My
apartment where
kind of
she was
lady.
living. Yeah. When
Listen,
she,
every great true crime story starts with they popped the patio door on the ground floor apartment. So I'm with her. Like if you're on the second floor, at least they're gonna have a harder time getting to you. Okay?
right.
I get
Right.
it.
But,
I
she
get it.
couldn't do things like answer the door, so we had
Right.
to, like, I had to get in
Yeah.
contact with her landlord and I was just like, hey, this is our situation. Can
Yeah.
we put a keypad lock? Like, there's just
Yeah.
all kinds of like little things. And then I started to go down the road of trying to coordinate like caregivers and stuff like that. But I quickly realized, you know what, let me just pay this money because because then the staffing of the court is somebody
Yeah.
else's problem because and
Yeah.
here is an important part about hospice. You have to have a caregiver. We as hospice nurses cannot leave you alone in your home to die and have us find you. I mean,
Mm-mm. No.
I have I have I've
No.
had it happen. I've had it happen with people um who were just obstinate
Yeah.
that they weren't going to have a person caring for them. And yeah, I mean, I arrived one time to my hospice patient's house and I told him the night before, hey, I'm going to be there at this time. And he's like, okay, I'll leave the door open for you. I'm really glad he did because he
Bless it. He was
was
gone.
gone to the great beyond by the time I got there. So, it's just, and he didn't have anybody living there. And
Yeah.
imagine if my visit wasn't set for that day. Like, so we obviously prefer that you have a caregiver because those situations can be
Yeah.
messy and for lots of reasons.
What are your thoughts? And this is just sort of we're going to take a segue. We're going to, we're going to go side topic. Because we as an American society are so focused on work and career and productivity and making money, etc. We've gotten away from having people in our family that are caregivers. And I'm not saying that we right or wrong. It is what it is. I mean, we can go into all sorts of reasons it happened, but when you've got two, both spouses or partners working, you have children or you have aging parents, like who's caregiving? When your parent is sick, who is caregiving? When your child is sick, who is caregiving? Like these are real struggles, and we've just sort of been patching it. I mean, we have at my house for almost 3 decades now. We've had, these spot patches at different stages of life. When we only had one kid, we were able to do this, and then we had two, and then we went to four, and and now we have one that's special needs, and we don't know any day what the day is going to look like, and we're very much struggling, and we have parents who are aging and ill, and we don't feel like we're doing enough caregiving for them. So I think as a society we need to think about that. When we're working 60 hours a week, there's no room for caregiving. You're barely surviving. And so when you're
Yeah.
faced with a situation like this, it's going to slap you square in the face rather than, is it possible from the beginning? And I'm working on this with my kids because they're just about to enter the workforce full time. My first one's about to leave the nest next year. And I've started asking all of them, what do you want your life to look like? Not how much money do you want to make? What house do you want to own? What do you want your life to look like? Do you want to work all the time? Do you want, like, there's nothing wrong with financial success. I'm all for it. But are you willing to trade what that may cost you in the long run? Because it's going to cost something. And
Oh, absolutely.
I think in
Absolutely.
the caregiving, in the hospice caregiving sphere, like I know when my grandmother was on hospice, I had seen her the week before. And looking back now, I should have just taken LOA and said,
Hmm.
deuces. I'm going to go sit with my grandmother when she dies. I felt so obligated to a company who could not see fit to give me a raise the next year. We won't get into that. After making them financially profitable, after literally taking them from red to black, guys, I asked for a
Sing
very
it,
small raise.
sister.
And I
Sing
did
it.
not,
As I sit
I,
in my house in West
I,
Texas, actually leaving a
yes,
job that, yeah. Hmm.
I did not get that very tiny raise, but I felt so obligated to them that I missed out caregiving for my own grandmother. And I was like, I will never do that again. I will never. So I have consistently since that time made changes, and I'm about to make another large life change in a couple of months, I think, because I don't want that to be I don't want to be in that sphere again of my parents need me, my in-laws need me, my children need me, and I can't do it because I'm obligated to this corporation and they're tapping their toes and they need something from me that that my family should be getting.
I will say that, so I kind of had, when I left my job at UAMS, it was after my mom had been diagnosed, and that wasn't the main reason. And
Yeah.
I left, but it was kind of one of those situations too where I had to really step back and look at what my
Mm-hmm.
life had become and whether
Mm-hmm.
or not this dream that I had was worth the sacrifice of my personal life
Yes.
and the stress
Yes.
of being on call 24/7
Yes.
and being the
Mm-hmm.
only person who knew how to do your job in the
Yep.
institution and the
Mm-hmm.
guilt that it felt like when I took my first vacation after we hired the person who was going to run the transplant program, the doctor. um I had to go because I actually came to Snyder, and I was here in Snyder when all of this stuff was going on, and I had to go to town every day of the week for an allotted times to answer emails and phone calls and stuff like that. And at that time I was so eager and happy to do it. You know what I mean? Because it was just like, oh,
Yeah.
this is my dream. This
Well,
is
this
going to
is
be
my
so
dream. This is what I've
right. This
worked
is
so
going to
hard
be
for.
so amazing for Arkansas to have the ability to have this program in place, and I felt so honored.
And it is
And
amazing. It is
yeah,
amazing, but it
and
shouldn't
and
come at the
I'm
cost that it did.
but it did come at a cost. And
Hmm.
so, and
Always
that
does.
even this place that I had grown up in. I mean, I grew up at the University of Arkansas, and
Yeah,
I had the
same,
privilege of
same.
having some of the best mentors in the world. Like,
Yeah,
I cannot rave about
yeah,
Dr. Laura Hutchins enough. I mean, the woman, I have seen her be powerful in rooms where no one thought she had a need to have a seat at the table. I have seen her
yeah,
command spaces. Just watching her as I was growing as a nurse really, really gave me a lot of empowerment. And then just the teaching aspect of how much she
yes,
cared about,
yes,
making
yeah,
sure that the people she was teaching were thinking about the continuum of care for these patients. And
yes.
standing next to her on rounds when she would say to her young doctors, what would you do if this were your mother? And I mean, I was enamored with all of that. And it was just, so when I finally had to take a really hard look at, okay, this is all the stuff that's going on in my life, and at that point, the thing that was causing me the most strife and stress was my job, because I was making
Mm-hmm,
peanuts. I was
mm-hmm,
doing the work of 4 people. They
mm-hmm,
refused to hire adequate staffing and help because, they felt that at some point we'll get there, So, like, at the beginning of the program
yeah.
building, I
They want
was the
it to
clinic
be, yep,
nurse. Yeah. I was
yeah.
the
They want
clinic
it to be
nurse. I was the
financially viable before they, yeah. Oh yeah.
before they hand out the money. And
Yeah.
unfortunately for me, I learned a hard life lesson that when
Yeah.
people promise you things, you better get it in writing.
Right. Right.
And so at the end of the day, when I had sacrificed all
Everything.
of those things to help the patients of Arkansas, which, I mean, don't get me wrong, I am still incredibly proud of the work that I did,
Yeah.
and the help that I gave to something that still is so near and dear to my heart. I mean, if there were a place for me down the street to go do bone marrow transplant, I would do that. That's what I love to do. And the impact that those patients had on
Do you
me,
hear
it's
that,
just
world? Heather is available for a bone marrow transplant unit near her in Texas.
right. I mean,
Universe, get on it
right. I mean,
now.
I love that, but I know a lot more now than I did just about.
Yeah.
It was funny because I had an opportunity about 8 or 9 months ago to help form another bone marrow transplant program, and I talked to one of my mentors. Her name is Dr. Michelle Fox, who is also another brilliant, brilliant woman who I adore, and happens to be a fantastic artist as well. She's wonderful. But she told me, she's like, well, Heather, she goes, if you like your life,
Right.
don't do it.
Right. Right.
And so at first I was just like, well, damn, not
Yep.
what I wanted to hear. But life
But
is
she's
precious.
right. She's
Yeah.
absolutely right. Like,
And I could not drop everything and go care for my mom. I could not,
well, our
make her
society
priority.
doesn't allow for that. Our
Right.
society is not built for that. And so I think what I want our listeners to hear is that if that is what's going to be important, if you're okay with someone else caring for your loved one, and listen, there's no shame in that. That's
Mm-mm.
okay. If you know you're not built for that, that's all right. Look, there's no judgment involved in that. Go for it. But if you're someone who is going to look back later and say, I should have been there, even with the nurse there, I wanted to have been there. I wanted to be there. I wanted my daughter, parent, loved one, I wanted to be holding their hand. I wanted them to know they weren't alone. Then you need to think about that from the onset of your careers, from your career
Yes.
choices. Or if you're in the middle of it, I will say this, it is never too late to pivot. I don't care how much debt you're in. I don't care how hard it seems. I don't care how scary it is. Heather and I will do some shows about some scary shit we have done in life to pivot, and that we are doing to pivot to sort of correct those wrongs. For us, they were wrong. And you know it's wrong when it feels bad here, when you can't breathe and you can't speak, and the pain of knowing that you can't get that time back
Mm-mm.
is almost too much to bear. You know you need to pivot.
Yes.
Because I mean, personally, I have made the decision. I don't ever want to be in a position again where someone that I love needs me and I have to tell them I can't be there.
Yeah.
I
Yes.
just,
Absolutely.
it's not a thing in this world that is a material possession is worth it. Not
No.
a house, not a car. I don't care what you got. I don't need it. I don't want it. What I want is for the people in my life to know how much I love them. And I
Mm-hmm.
think that for me, that is expressed through caregiving,
Yes.
for being there
And
when they
like,
need me.
and now, and even at the end of my mom's life, when I was working as a hospice nurse, um, when I left to go up, and I believe this was when we enrolled her in hospice. I went up there and I spent a week because the cancer had come back a second time in the brain, and they had already done whole brain radiation. They had already done all of those
Yeah.
things, and there was nothing else to do. And my mom was starting to do some really strange things because, like I said, she wouldn't quit working.
Right.
So she was like, her boss was calling me, telling me she showed
Yeah.
up at 3 a.m. and was like calling me at 3 in the morning, like, where is everybody?
Right.
And starting to show some real signs of decline, and so having to go through all that process. So I left work to go up there, and I made the mistake of telling them, I'm like, I know I have documentation to catch up on. I'll work on that some when I was there. Do you know that those people called me and bothered me every day?
Yes. Yes, I do know.
And
I mean,
and
you didn't have to tell me for me to know that, because I know what the medical space is like. If you have any level of responsibility, it doesn't matter where you are or what you're doing, they will call you.
and what I
They will
did
call you.
was I came home after my mom passed away. I came home and I started looking for a job because, and what I should, in hindsight, of course, I'm the breadwinner of my family. So it's not like you can just toss all
Right.
caution to the wind. I was not
No,
in a position where I could do that.
it's called an
But
exit strategy.
I'll tell you, this is one thing that I feel like kind of ties both of these pieces together is, and sometimes relationships don't allow for that. In my mom and I's
Mhm.
relationship, we had a weird relationship. Um, we loved each other very much. We loved each other fiercely, but I think that because of all the trauma that we had been through together, we were just not able to have a solid, regular mother-daughter bond.
Sure.
Um, my mother-daughter bond was more with my grandmother because we were together a lot more when I was younger, and that
Mhm.
relationship was a lot more stress-free.
Right.
um there wasn't a lot of like abuse or neglect or
Right.
anything going on in that space, and so my grandmother was the person who sort of was that soft maternal space for me, where my mom and I, we really struggled a lot, and I was hell on wheels as a teenager. So I was not easy.
Shocking. Shocking.
I know when my grandmother.
Supposedly, I was hell on wheels too, but I was not. We can talk about that later. I absolutely was not. But I do believe Heather was.
Yes, absolutely. I own 100% of that. And so I know that, like, my mom also carried a lot of guilt of just because of the way my childhood was,
Right.
and her choices as an adult. I don't think that she wanted me to make the sacrifice play. But had I
No,
known,
probably not.
had I known what her financial situation was, had I known all of that stuff, I probably would have told that job to go fuck themselves and cared for my mom, because at the end
Right.
of all things, she had enough money for me to
Right.
be have been able to do that, but I didn't know.
Right. Who knew? Who knew?
Right. So I'm thinking
Yeah.
I'm having to split myself into these two spaces, like
Yeah.
breadwinner, daughter, and trying to find some kind of it, it just it didn't work. Um
No. No. Because
so
there's only so many pieces of you.
right, there's only so many pieces that to go around, only so many meat slices. So,
Right.
and I was definitely operating at a deficit, and caregiving is a major part of that. It's a major part of the hospice process. It's definitely the most unsupported part of the hospice process. Now, there are
Yes.
programs out there, that, like Medicaid, if your loved one qualifies for Medicaid, has an option where you can actually be paid to be a caregiver for so many hours a week, which
Hmm.
really helps some folks do that. But I think it's only like maybe 20-25 hours a
Yeah.
week. And the
Yeah.
pay is very low. Like, you are
It
getting
is.
paid, but it's very low. It's only like 10 to
Yeah.
$15 an
It's not
hour.
much. Yeah. It's not much.
But it is a thing. And I think that Medicare was talking about doing some kind of like home caring stipend as well. But we didn't get there. And that's, of course, another topic for another day. What
Number
things will become of Medicare?
112 on the list.
Yes. But it is definitely something that we skip over a lot when it
Yeah.
comes to talking about the end of life. Like, who is actually going to be doing that work?
Right.
and
And it is
and
work. It is
what
work.
is the financial sacrifice to the person who is going to be tasked with
Hmm.
doing that? And
Yep.
it's heavy, especially if you're in for a long drawn out situation.
Yeah.
If your loved one is elderly and bedbound. I've had patients that had really serious dementia who they came on hospice because they broke their hip and weren't surgically able to undergo a fixation. And so now this person is bedbound with a broken hip, in an extreme amount of pain, with dementia, doesn't remember that they're not supposed to get out of bed. And, the work of caregiving for those patients is a whole lot different than, say, a
Yeah.
person who has cancer, who's on the pathway of you're good till you're not. and your active phase of dying is a week, maybe two, you know, just the whole spectrum of things that can happen. And, and then the fighting in families. Let's not even, there's a lot of that. You have a lot of interesting
The
family dynamics.
hallway fights that we have witnessed.
Oh, yeah. Yeah. So,
And I'm sure you've seen this too, but I have seen patients have to die by themselves because the family couldn't agree on who was going to be there when they died, or they quote unquote couldn't handle it. And hospital staff, pharmacists, respiratory therapy, like we all would take shifts off the clock because that person was actively dying and their family could not get their shit together for somebody to come sit with Meemaw.
yeah.
And I was just like, what? Or I don't like hospitals. We don't care what you like. We don't, Cousin Philip, we don't care. We do not care if you don't like the hospital. I'm sorry. That person needs somebody there.
Yes. It is that part. It's so hard because, I think hospice was really healing for me in a way that it helped me understand that I was not the only person who had these struggles in my family. So in a way, it was very life affirming to kind of witness other people's mess, because I was like, okay, well, maybe maybe it's not so bad.
All right, Heather, I'm glad you mentioned that. Let's make a news announcement. Everybody's family is crazy in a different way. And everybody has trauma and they have drama, and that it just is. It is. And the sooner you embrace it and stop trying to hide it from people, the better you're going to feel. First
For
of all,
sure.
your give a damn will be absolutely gone. It will just be busted to hell, and you won't care anymore what anybody thinks. And there's a lot of power in that. And also, I think there's a lot of healing that occurs when you
Yeah.
stop pretending that everything is okay when everything is not okay. And somebody hears about it. I mean, my life and yours, quite frankly, they're pretty much an open book. I just, and it was like that long before I had the podcast. We had the podcast, but
Right.
People will say sometimes to me, well, you mentioned this in an article that you wrote, or you mentioned this in a post you made, and I didn't know, like, that's exactly how I feel about that. And I think it's important people know it's how everybody feels about it. They just don't want to say it because they think it makes them look bad. It doesn't make you look bad. It makes you look human.
Yeah. Interpersonal relationships, no matter what they are, can be very messy. They can be
That's
very
the
messy.
definition of them.
And
That should just be called messy.
and even in situations where you think that people are gonna behave in a certain way, I mean, you
No,
could
they're
definitely
not.
get a wild card. Like, you just never know.
No, they're not.
And how and death, especially when we're dealing with death and
Yes.
dying, and the
Yes.
finality of that. Like my mom buying her sewing machine, trying to, finish her 47 million half done
Hold
project.
on.
Yeah,
I
and I'm
love
just
that.
like,
I love that. That is
okay,
me.
mom.
That will be me. That will be me.
um
Yeah,
okay, so we've like done like a major side quest here.
we did, but it's okay.
So
Those are the best kinds.
next on the agenda, pharmacy benefits.
Oh,
Um, so when you have a hospice diagnosis, and we talk about like what hospice is
uh-huh,
paying for.
uh-huh.
So if you have a cancer diagnosis and you are approaching the actively dying stage, and you are requiring comfort medications, whatever they may be, hospice picks up and pays for all of that. Can you like clarify, like, what did you do any of the did you work with the bin numbers and all that stuff with hospice, like when you were doing pharmacy stuff?
Oh, you're speaking my language. Yes. So I was just gonna let you talk. You were like pharmacy benefits. I was like, oh, she's got it. I'm gonna nod and yeah. So so the way that it works is your hospice physician is taking over your care. However, hospice is only going to pay for what is directly related to the care involved with hospice. So that means they won't pay for your Viagra. Okay, that they won't.
I have had a
All
patient
right.
ask. I have.
And unless you actually have primary pulmonary hypertension, they might pay for it then. They're not. It's not. I mean, that's the best example I know to give people, right? Like, but they're going to pay for the morphine. They're going to pay for the lorazepam. They're going to pay for anything that we need to keep you comfortable and to keep you reasonably stable. Like, they're not going to stop all your blood pressure medicines and things like that. Now, they may not pay for your Ozempic anymore. That's not their jam, but you won't have to worry about those costs. The catch to it is they will only pay for 15 days at a time because you're on hospice and they don't know how long you're going to be with them. So though that can be a little annoying that you got to come to the pharmacy or send somebody every 2 weeks, but your nurse can come pick it up too if they're available to do that. Like, it can be arranged that your nurse is going to get it on the way to your house or something like that. Especially in rural areas where, you've got older people who maybe the spouse doesn't drive and they got to have some help. And so a lot of times that's arranged as well. The billing process changes. And so we get a whole new set of billing information for you once you go on hospice, and every company has different billing information. And that makes it, we had a lot of fun with that this weekend for a new hospice patient. None of that's universal. We, contrary to what the general public thinks, pharmacy staff, we don't have, like, we are not mind readers. We don't have ESP. When we receive a prescription for you and they say it's hospice, like, they fax it to us sometimes, and it just says hospice. If they don't provide me billing information, I don't have your billing information, you know. And it's important that whoever the number that they give you for after hours, you need to have that readily available at all times, because that's the person you're going to be calling if the pharmacy hasn't received the prescription, if there's a problem with it, if the billing information isn't working. You need to know who to contact when all that is happening so that we can make sure you get those meds. Because the last thing anybody wants is for a hospice patient to be in pain all night, but I won't lose my license over it. Like, I'm not going to let a controlled substance go out of the pharmacy, even if they're a hospice patient, if I don't have, you know, the prescription, if there's a problem with the prescription we haven't gotten fixed. Like, if there's anything that's going to cause me to break, federal and state regulations, I'm not going to do it. I don't know a pharmacist that would. If they do, they're not telling me about it, and because it's not worth it. Now, that does not mean we're not empathetic. We will stay late. We will come in early. Like, we will miss our lunch. Like, there's a lot of things we'll do for hospice patients and a lot of things I have done. Um, and I'm always glad to do it. I hate that the situation is what it is. And anytime my hospice patients get my cell phone number too. Not always, just kind of depends on the situation. But if I can tell the family's really struggling and maybe they're just like shell shocked, and that, a lot of times they come to pick up and they're just like, you can just tell by looking at them. And by law, I'm supposed to tell them all about this medicine, and I am, but I can tell they're not getting every fifth word I'm saying. Then they're gonna get my cell phone number as well, even though I do work for a big chain, because I'm gonna get a phone call. I mean, it's
Yeah,
just, I'm gonna get a phone call, and it may
I'll
be
tell
after
you
hours.
where I am